I need 2 minutes, Connie, just a second to get all my notes in place. In the meantime, I'd like to welcome everyone. My name is Salvo La Rosa. For those of you who don't know me yet, I'm the Chief Scientific Officer of the Children's Tumor Foundation. And I'm really, really happy to be here tonight for the meetup, but also for the content that we're gonna listen very soon. I would say if you guys give me a minute, we'll wait for everybody to, maybe there is some late person that will join, and I'll be with you in a second. I just had some problems getting on board on the meeting, but I'll be
no problem.
in a second.
No worries, Salvo, take your time.
Mm-hmm. Okay, so here we are. So our today we're gonna listen from Dr. Leslie Kim, and then after her talk, which is very interesting, we'll have a Q&A. So I'll be monitoring the chat. So you feel free to drop any question at any time when you have it in your mind in the chat, and then we'll address it at the end. I don't know how Dr. Kim wants to address questions as they arrive, or at the end, but she will let us know. And then at the after the presentation and we cover the Q&A, I will go through the NF Summit NF2 content just for 5 minutes, scrolling with you some of the agenda and for NF2, and see what is important there, what I'm looking forward to, and interesting topics that will be discussed. I hope you guys will join either in person or virtually to the summit. But here we are, for our main course tonight, and Dr. Leslie Kim, welcome, first of all, and join us. Dr. Kim is a clinical associate professor, division director of facial plastic and reconstructive surgery in the Department of Otolaryngology, Head and Neck Surgery at Ohio State University Wexner Medical Center in Columbus, Ohio. She graduated from Northwestern University Honors Program in Medical Education and completed her residency in Otolaryngology, Head and Neck Surgery at Ohio State, followed by fellowship training in facial plastic surgery at Johns Hopkins. Her practice focuses exclusively on aesthetic and reconstructive surgeries of the face and neck, including substantial tertiary care practice in facial reanimation. And tonight we're going to hear a lot of this. So welcome, Dr. Kim. The floor is yours. You can share slides whenever you're ready.
Thank you so much, Salvo. I'm going to try to share my slides first here. And let's see here. Oh, here, let me do this again, actually, sorry. Share screen. Okay, does that work? Perfect. Okay,
yes,
so I am not so savvy. I'm trying to figure out now to get the chat to show up on the sides while I talk. So I'll address questions at the end if that's okay with everybody. So I'm going to speak today on contemporary facial reanimation. Thank you so much for inviting me to speak to all of you. And let me make sure I can go forward. Perfect. So whenever I talk about facial reanimation with patients, and I know that Salvo and Connie, we talked about how sophisticated you all are in terms of your knowledge about the facial nerve, about facial reanimation, but I think it's really helpful to start with the basics. So I'm going to start by talking a little bit about the facial nerve. So the facial nerve arises from the brainstem, so deep in the head, and then it comes out through the temporal bone, which is the bone behind the ear. And it sends off, it goes through the bone behind the ear and it sends off branches as it goes along, and then it exits kind of deep behind the ear in an area called the stylomastoid foramen. And so what's really relevant about the facial nerve is it's a big nerve. It has 10,000 neurons, and neurons are like the firing parts of the nerve, and 7,000 of them innervate or give energy to the muscles of facial expression. So it's a big deal. And when the nerve exits the stylomastoid foramen back behind the ear, it then travels within the spit gland of our face to send off multiple branches all along the face to, again, bring energy into the face. This diagram is really hectic, but why I show this is to show that in the middle of the face, there's a lot of cross innervation. So what this means in terms of just counseling for facial nerve recovery, for instance, is that you're going to see more improvement in the middle of the face before you see improvement in the forehead or the lower lip. And that's really relevant because when patients come to see me and they're very bummed out because, you know, they say, hey, I have facial paralysis, my forehead doesn't move, I'm really upset about it. I'll often say, wait, I see a little bit of improvement in the fold of your cheek. And wait, I see that your lower lid isn't so saggy. And I'll give some guidance that the facial nerve is going to recover more in the central part of the face because there's all of this cross innervation before it goes up into the forehead and the lower lip. The other thing that's relevant about this picture is when we talk about facial reanimation, we're capitalizing on this cross innervation. What that means is when we're doing, for instance, smile surgery, we want to find branches that do the smile, and there's usually more than one. And so we can utilize that when it comes to facial reanimation. So significant amount of overlap, as I said. So we have 43 muscles of facial expression in the face, and the purpose of the facial nerve, as I explained to patients, is simply to bring electrical energy into these muscles that actually move the face. So moving on to facial paralysis, when we talk about the etiologies of facial paralysis, the most common one is Bell's palsy. Might have heard recently that Justin Bieber got Ramsay-Hunt syndrome, which is another type of virus that we think affects the facial nerve. The very common, especially in tertiary care centers like Ohio State, this study is out of Harvard or Mass Eye, vestibular schwannomas or acoustic neuromas represent a pretty significant portion of the facial paralysis that we see. And that certainly affects a lot of you who are affected by NF2. So when I evaluate a patient with facial paralysis in the office, first thing I do is get a thorough history. I want to know why the paralysis is there, what is the onset, what is the duration. I'm looking really into the age, the medical history, and current function. And what's relevant about NF2, as you all know, is sometimes you can have bilateral tumors. So I need to know about the status of the other side. Both sides, is one side affected and not the other? And we need to know about all of the nerves that are potentially affected. And so the physical exam is going to include a complete cranial nerve examination. I look at the face in the upper, middle, and lower thirds. Then I try to classify the paralysis. Is this complete paralysis? Is this incomplete paralysis? Because you can have a whole variety of presentation in between. I take photos and video to document the appearance at rest and through a wide range of movements, and then use paralysis grading scales just so that we can communicate. I know many of you are familiar with such as the House-Brackman scale. So complete paralysis is your classic stroke look where the patient has flaccid paralysis or a droopy face. So as you can see here, when you have complete paralysis where no energy is going to the face, we see a forehead that doesn't move, an eye that doesn't close. So opening the eye is a different nerve, so it's unaffected. The lower lid starts to droop. You lose the fold of the middle of the face, the corner of the mouth droops, and everything sort of sags. Now, flaccid paralysis or complete paralysis is going to look different in a young person versus an older person. So a young person may not look so bad when they have flaccid paralysis because they're young and their skin tone is good, and so everything still kind of hangs in there, whereas somebody who's older may have more drooping because things are just, gravity fights against us, unfortunately. When it comes to incomplete paralysis, this is where things start to get tricky because incomplete paralysis might mean complete paralysis that's recovering, or it could be complete paralysis that recovered too much. And what I mean by that is you can get varying degrees of something called synkinesis. And I'll talk a little bit about that later. But synkinesis, the best analogy I give to patients is imagine when you have droopy face paralysis, all of the stereodials, all of your facial muscles are turned off. And then as the nerve starts recovering, it starts to give energy to the muscles, the stereodials start turning on again. But then sometimes what we get in synkinesis is what we call aberrant regeneration, meaning the nerve regenerates, but it regenerates in a funky fashion. And so the stereodials start overturning. And so you can get mixed movements in the areas of the face. And so this is an example where the patient goes to smile and their eye squints smaller because the eye is a circle muscle, so it pulls in. And so the eye muscle tends to be on too much sometimes, whereas before it wasn't working. The corner of the mouth gets pulled up because all those smile muscles are working in overdrive, they're tightened. But then at the same time that the smile muscles are turned up, the frowning muscles are turned on at the same time as well. So there's kind of a tug of war that happens at the corner of the mouth when there's incomplete or non-flaccid synkinetic paralysis. So I'll talk a little bit more about that at the end of the talk. So when I see a person come in with facial paralysis, to me, the number one objective, most important thing at that moment is to protect the eye. And the reason why is the eye has a covering called the cornea, and the cornea protects the eye. But when we can't blink and close the eye, that cornea can dry out, and that can lead to something called exposure keratitis. And if that's untreated, it could lead to blindness. So that's a big deal. So the first things first is supporting the eye. So lubricating it with drops and ointment, moisture chambers or like coverings at nighttime, taping. You can get bandage contact lenses. So whatever we can do to protect the eye and moisturize it, that's very important. When it comes to the upper eyelid, it's fairly, I don't want to simplify it, but there's a sort of limited number of options for the eye. So upper eyelid loading or putting an eyelid weight is the most common thing. I myself prefer platinum weights because they are a little bit more dense than gold. So you can get a thinner weight in, so it's less visible when you go to close your eye. And so a weight goes into the upper lid to help you try to close your eye and help you with the blinking. And then lower lid position and function is also really critical. So where possible, you want to tack that lower lid up so that it can help get close to the eyelid and help protect the eyelid as well and help to disperse the tears when you go to blink. And so, you know, this is a classic example of some of the eyelid surgeries that we do for facial paralysis. This patient had a weight placed in the upper eyelid and a lower lid tuck up.
Excuse me, Dr. Kim.
Yes.
There's a request for you to slow down just a bit because the captions are not keeping up with your talk.
Oh, so sorry. I will slow down.
Thank you so much.
Okay. So moving on to dynamic facial reanimation. So when I see patients with facial paralysis, one of the most common things that patients say is, I want my smile back. So to me, while the eye is functionally the most important, I find that patients most often talk a lot more about their smile in the middle of the face. And so when we talk about trying to make somebody with facial paralysis better, we want to use dynamic techniques instead of static techniques so that we can restore movement. So static techniques just simply means suspending the face. So when we talk about dynamic facial reanimation, what's really important to know, and I don't say this to scare you, but the clock starts ticking for the facial muscles from the day of onset of the paralysis. So while we often harp on and talk about the facial nerve, what's actually important are the facial muscles. And that's because any muscle in the body that does not get innervation from the brain for a prolonged period of time, we think maybe about 2 years, develop wasting. So this is an example of wasting. So they develop atrophy and fibrosis resulting in what we call irreversible paralysis. And what irreversible paralysis means is that no matter what you do, you can't turn that muscle back on again. So when that muscle can no longer be turned back on or made come back alive, then we have to actually replace the muscle. So I'll talk about that. Versus reversibly paralyzed muscles are still alive, meaning they may not be moving, but they still have what we call intact motor end plates. So they are receptive to energy. So even though they're not moving, they are receptive to being to get energy from the brain to move again. And so what we want to do is re-innervate the muscles if we can, to try to get the facial muscles to turn back on, to try to restore tone or symmetry and movement to the face. And so when it comes to figuring out what procedures are possible, it really comes down to the reversibility, which is often just identified by how long someone's been paralyzed. So what does this mean? So this is busy, but let's break it down. On the left side, when we talk about reversible paralysis, that's generally paralysis under about 1.5 years or 2 years. And the goal in these cases is to re-innervate. So what we can do to turn the muscles back on again. And so in general, the most common procedures that are going to be offered are nerve transfers, where another nerve is brought into the facial nerve and muscles to try to turn them back on. And so the most common ones for those are your 5, cranial nerve 5, which is your masseteric nerve. So that's the nerve in the chewing muscle back here. 12, which is your hypoglossal nerve, or the nerve that moves half of the tongue, can also be used. And then 7, which is your opposite side facial nerve, or what we call a cross face nerve graft. On the other hand, if you are irreversibly paralyzed, so if you've been paralyzed for more than about 2 years, or sometimes you can have congenital absence of your facial muscles. In these cases, we want to replace the muscles. And so the most common options for that you might have heard of are regional muscle transfer, or what we call temporalis tendon transfer. We call that T3, or a free muscle transfer, or what we call an example of that is a free gracilis muscle transfer. And I'll talk a little bit about that. So again, when I'm thinking about a patient with facial paralysis, I'm really looking at the duration of paralysis to figure out what are my options. So here's an example of a nerve transfer. So this is a patient who had a brainstem tumor and underwent masseteric nerve transfer. So what does that mean? So this is before and this is after. So basically in surgery, I went in and found the nerve that allows this masseter muscle to clench. And I took that nerve out and rerouted it into the facial nerve that I think does smile, because in the operating room, we can sometimes use a nerve stimulator, but it doesn't work in facial paralysis. So I have to sort of guess on what nerve I think does smile, and then I hook them up under a microscope. And so you can see here, she has an eyelid weight that I did not place, an eye surgeon did, but she has to clench to smile. And when she clenches, the nerve that used to go to her jaw muscle now goes to her smile muscle, and she's able to smile again. So this is an example of a nerve transfer. Very often I'll do combined nerve transfers. So this is an example of a patient who had a very large vestibular schwannoma who underwent masseteric nerve transfer. Again, jaw muscle, that clenching nerve is taken out to be able to smile. And then I also transferred the hypoglossal nerve, which is located in the neck. And that's the nerve that does half of the tongue. And why do I like to do both? Well, the tongue is on all the time. The brain is sending energy to both sides of the tongue all of the time. And so you can borrow a part of one side of the tongue nerve, so just on one side, and transfer it into the facial nerve. And what this allows is constant energy going into the face. So that is a really helpful nerve for establishing tone. Tone means muscle activity at rest. And that muscle tone is what allows us to be symmetric. And so, she's a bit younger, so it's harder to see her paralysis, but you can see her eye is really big. She had an eyelid weight placed, and how you can tell that the nerve transfers are working is now the eyelid weight is too heavy because her nerve is working a little bit more. Before, it's a little harder to tell here, but her lip was really pulled over to the right side. And now in this 10 months later, you can see the lip is much more midline. And so you can see that there's more tone that's happening. And then she clenches to give herself a bit more of a smile. And then you can see that when we do nerve transfers, we will expect synkinesis, which again, I'll talk about later. So when she smiles, that eye gets a little bit smaller. But again, more of a smile and more symmetry at rest. Sometimes in an older patient in particular, I'll combine nerve transfers with suspension. So static suspension to tack up the corner of the mouth. So this is an example of somebody who had facial paralysis, already had eyelid surgery, but you can see there's no fold. The corner of the mouth is droopy. And so I did a facial nerve repair, nerve transfers, as well as a suspension to allow him to look more normal at rest, but also be able to regain his smiling. So moving on to the opposite side of the diagram where I was talking about irreversible paralysis. So when muscles are congenitally absent or irreversibly paralyzed due to prolonged innervation, so not getting innervation from the brain for more than 2 years or so, muscle function must be replaced. So as I talked about, the most common is temporalis tendon transfer. And that is when this temple muscle is connected to the jaw. And so I could take it from inside the mouth off of the jaw and connect it to the corner of the mouth so that when you clench, because this is a jaw muscle, then you're able to smile a little bit. The other option is what we call a free gracilis muscle transfer. So what this is a tissue transplant. And so this muscle called the gracilis muscle is a muscle in the inner part of the thigh. And it's a tissue transplant because when you take it out of the thigh, you have to take the blood vessel. So this is the artery and the vein and the nerve out that moves the muscle in the leg. And so when you transplant it into the face, you need to hook it up to an artery and vein in the neck so that the muscle can be alive, so the blood flow comes through. But you also need to connect a nerve to the muscle so that the nerve can move, or the muscle can move. And the nerve options that we use in a gracilis are all pretty much the same ones I already mentioned: the masseteric nerve, the tongue nerve, and the other facial nerve. So those are the most common ones that we use to try to get this muscle to move and smile. So here's an example. I think this is a cool intraoperative example of a temporalis tendon transfer. So basically in this video, what I'm doing is stimulating the temple muscle. And when I do that, you can see that the corner of the mouth moves upward and that's how the patient's able to smile again. By activating or clenching, the corner of the mouth moves. This is a patient who had a free gracilis muscle transfer, and you might ask, what is the difference? The smile that you get out of a free gracilis muscle transfer is almost always better than what you get out of a temporalis tendon transfer. And so this is a patient with NF2 who underwent gracilis muscle transfer with I used 2 nerves. She didn't really have a tumor growing on the other side, so we used a cross-space nerve graft So the other facial nerve connected, as well as the masseter nerve, the chewing nerve. And so when she smiles, she's able to clench to get a big smile, but she can also smile a little bit spontaneously, meaning she doesn't have to clench. So she gets a little bit of both. So moving on to the question that I get a lot from patients and other doctors as well is, when do we do things, right? And so a common scenario that can happen after tumors is when the nerve was intact during surgery, but the patient wakes up with facial paralysis. And that's really tricky because, you know, the classic thing that we do is wait at least 1 year to see what happens to the nerve, because we say, let's just see if the nerve will turn back on again. But as I said, the clock is ticking for the muscles. And so the longer we wait, the less likely that the muscles will turn back on. And so we can wait a year or so, but we risk continued degeneration and decreased success of later surgery. Alternatively, we can proceed with early facial reanimation and nerve surgery, but then we might be harming a nerve that would recover on its own and perform unnecessary surgery. And the other thing that I don't put here is that a lot of patients who undergo, for instance, vestibular schwannoma removal are in no shape to have surgery anytime soon because they really want to recover from the balance and hearing on all of these things. And it's a big surgery. So they're not very excited coming in and hearing about yet another surgery, right? So what is a way to think about this? I'm sharing this research paper from about 10, 11 years ago, and this was a big paper that came out of Johns Hopkins that reviewed 281 patients with vestibular schwannoma. And what they found, to simplify this very complicated diagram, is that if you had a complete facial paralysis, so initial Housebrackman 6 is considered complete facial paralysis. Housebrackman 5 is pretty close, maybe slight movement, but really complete paralysis essentially. How much you recovered in the first 6 months was very indicative of how you were going to recover. And so if you look here, if you started as a Housebrackman 6, if you were going to have a good outcome, which are these boxes, you were going to recover much quicker. So good is down and bad is up. And so you can see people who ultimately had a good outcome went down much faster or recovered much quicker. And so what they concluded from the study was that if you don't see a substantial improvement after 6 months of facial paralysis, it may be worth starting to think about doing reanimation surgery, because the prognosis of you recovering on your own, unfortunately, goes down as more time goes on with no recovery. So this is something I use in practice, where around that 6-month mark, I'll start the discussion for facial reanimation if I see that somebody is still very paralyzed. But we can't predict everything. So what does this mean? So this is a patient who does not have NF2. She actually had what we call a cholesteatoma, which is a benign thing that happens in the ear that unfortunately acts like a tumor. So it can create facial paralysis. And so this is a younger patient, 20-something-year-old, who came in to see me for the first time 2 years or so after having paralysis. So she was like this for 2 years. Every nerve reanimation surgery takes many months to work. And so if you do a surgery in her case, I did it at 2.5 years. A masseteric nerve transfer can take 3 to 6 months to work. A hypoglossal nerve or tongue nerve transfer can take 6 to 12 months to work. So I did the combination of both in this patient, but I told her, you know, I think there's maybe a 20% chance that you get anything, because it's already been 2.5 years And all the surgeries I'm going to do are going to take another 6 to 12 months. But you can see a year later, she had an improvement in tone as well as movement. So what I mean to say is we cannot predict everything. It is the practice of medicine. And so when I see somebody, sometimes I just get a gut feeling that it will work, or there's a gut feeling that there's a chance of something working. And to me, I'd rather take a chance on nerve transfers than go right to a gracilis, because when we do nerve transfers, we're sending energy to the muscles we already have. When we do a gracilis, for instance, and take a muscle from the leg and move it to the face, we're only making one muscle movement, just smile up and down. We're not able to innervate or re-energize a lot of the muscles in the face, which is why I prefer nerve transfers if possible. Okay, so I'm going to just end with a few slides about post-paralysis facial synkinesis. So I talked a little bit about this. 15 to 50% of patients who recover from facial paralysis develop synkinesis. So in this patient, you can see when she goes to smile, her forehead goes up. So if you ask her to move her forehead, she can't do it, but it does go up. So the positive thing is the forehead muscle is alive. It's just not working that well. You can see when she smiles, her eye closes. You can see when she smiles, she can't move that mouth very well because the smile muscles, the frowning muscles, the lateral or the side pulling muscles are all kind of turning on at the same time. You can see that the chin dimples and the neck tightens. And why I like to talk about synkinesis is when people have synkinesis, a lot of other people will say, oh, you recovered, you look great. But people with synkinesis don't feel great and are often told by their doctors that there's nothing more to do because you've recovered. And I want to include this to say that there is still treatment for synkinesis. Synkinesis is a permanent problem, but just like any chronic illness, there are things you can do to try to make it better. So the first thing is therapy. That therapy is called facial neuromuscular retraining therapy. And it's a therapy to try to get the nerve talking to the muscles better again. So rewiring the brain. Neurotoxin or Botox. So as I said earlier, sometimes in synkinesis, the best analogy is that the dials of the muscles are turned up too high. And so Botox is a muscle relaxer. So you can inject it into some of the muscles to try to turn the dials back closer to normal again. And then surgery, which is often called selective neurolysis or selective myectomy. Basically, those are fancy words of saying we are cutting nerves and cutting muscles to turn the dials down. So cutting some of the nerve to reduce the input that's going that makes the face look tight and twist and spasm. So here's an example of one of my patients with post-paralysis facial synkinesis. And you can see at rest, raising eyebrows, soft eye closure, tight eye closure, soft smile, big smile, pucker lips. So what am I showing you here? I am showing you how when she moves her face differently, so closing the eyes, look how tight her neck is, her corner of the mouth gets pulled down. You can see it really significantly when she puckers her lips. You can see that eye almost closes, the neck is really tight. And so this is an example of Botox, and I just put excess. That doesn't show exactly how many injections I'm doing. I'm just kind of showing the muscles I'm injecting to get her looking more relaxed. So here's at rest, not a whole lot of difference. Tight eye closure, you can see that the neck doesn't bulge out as much. Big smile, you can see the corner of the mouth, which used to be pointing downward, is now more neutral. The eye stays more open with smiling. And with lip pucker, same thing. eye stays more open, neck isn't so tight. And so she did a combination of both Botox and therapy to gain this kind of improvement. And so there are treatments for the whole range of presentation for facial paralysis. NF2 can always make it a little bit tricky if other nerves are involved that we need to use for facial reanimation. But if they aren't involved, there are certainly options available. So that's the end of my talk. And I am happy to take any questions. I'm going to pull up the chat here and see if there's anything I can quickly see.
Thank you so much, Dr. Kim. Fascinating. I'm really, I mean, this is the first time I see such a presentation, and I'm amazed by the many different ways that you can treat paralysis at different stages, and this is really great. I don't know if there are any, there are a lot of patients that are actually struggling with some of the features that you highlighted, and I don't know if there is any specific questions, like, you know, facial paralysis after ABI surgery, for instance. One that's from Carol Emerson, and yeah, some other. I don't know if any of you guys wants to either type a question or come out of mute and address question, or, you know, curiosity or anything to Dr. Kim. Now you have an expert at your disposal.
Let's see. How much can cross-facial nerve transfer improve smile function, facial reanimation after masseter and hypoglossal transfers have already been performed? This is a really good question, very sophisticated question, because it's something I just recently offered this to one of my patients. It's hard to know. Cross-face nerve grafting is challenging because it requires us to get a nerve from the leg called the sural nerve. It's a nerve that does sensation on the side of the foot and the pinky toe. And that nerve is taken out, and so if this is my paralyzed side, we go to the normal side and we hook up this long nerve from the leg and go towards the paralyzed side. So the unparalyzed side is sending nerve energy to the paralyzed side. Why cross-face nerve grafts are a little trickier is because you have to go to the normal side of the face, or uninvolved side of the face. You have to cut one of the normal smile branches, then hook up the nerve from the leg, then hook up the nerve from the leg here to the nerve branch you want to hook up to. And so what I mean to say is research shows that when nerves travel across a connection, we lose maybe 30–40%. So a cross-face nerve graft, when it gets to the other side, is never that strong compared to, say, a masseter or a hypoglossal nerve transfer. But the benefit of a cross-face nerve graft is it gives you spontaneity, meaning that when this side goes to smile, the input goes all the way across and allows you to smile together. And so how much can it add? That's very patient specific. But what I say is the masseter and the hypoglossal nerve transfers go in faster. And so if you can save the muscles, then adding the cross-face nerve graft may give you a little bit more energy, but less, maybe a little bit more energy, but more importantly, maybe able to give you more spontaneous smile. So I would say the plus side of adding it is not so much in strength, but in coordination and spontaneity of your smile. So I hope that answers the question. So I'm reading, yeah. So vocal fold paralysis or vocal cord paralysis is cranial nerve 10. And so if he's a candidate or not actually requires an examination of all the other nerves to see. So 5 and 12, for instance, may not be affected, but we won't be able to tell unless an examination is performed. So I think it's helpful to see a facial nerve expert who performs these type of surgeries to get that input. Is there any surgery that can also regain eyebrow movement? Is it possible with different nerve transfers? I think that one is tricky, that there is some thought that the nerve transfers can help with eyebrow movement, but oftentimes the easier thing to do is a brow lift to lift the brow statically, and then Botoxing the other side to stop the movement so that it's not so obvious. So that tends to be the easier technique because eyebrow movement is only one branch usually. And so if you do nerve surgery, it's hard for that to go all the way up to that one branch, if that makes sense. Does massaging your face help? Is there anything you can do to avoid this or just management? Massaging your face can help depending on what your face is doing. So when you have synkinesis, for example, massaging is very helpful. Massaging is maybe less helpful when your paralysis is complete and droopy, but it probably doesn't hurt. The one thing we do not recommend as facial nerve experts is TENS units or electrical stimulation. We do not recommend that because the stimulation is not focused, it's not specific. For instance, it's not focused on the smile muscle, it just sends a lot of energy. And so we don't like that because it's not very effective. What can you do to avoid this if you have NF2? That's a very complicated question. It really depends on tumor status, management of the tumor, surgery, all of these things. I think that one is a little bit more difficult for myself to answer as I don't do the tumor management. Have you found that a history of treatments with bevacizumab impacts the outcome of facial reanimation procedures? I have not personally seen anything about that and facial nerve outcomes. I think that we do know that radiotherapy can potentially impact facial, can cause facial paralysis and might not be immediate and maybe later. Certainly surgery can. I'm not really sure whether bevacizumab affects facial reanimation or not.
There is a raised hand from Adam.
Hey, Dr. Ken, thank you very much for that. I should preface my question with, so I see Dr. Hadlock.
Oh yeah.
And the answer is, just you should talk to Dr. Hadlock about this. Totally fine, as she is my doctor. My question is, in 2015, she put in a muscle sling, just a static one. They were between dynamic and static, but at that time, I had some blood pressure issues, so they decided to just do the static one. And my question is, since then, in 2015, have any new procedures been developed that could improve upon the static nature of the facial muscle? Or is it just, this is how it's going to be, and any traveling with it would probably not help at all?
Dr. Hadlock is amazing. I know her quite a bit, and I think Ask Dr. Hadlock is a very reasonable answer.
Right.
I will say since 2015, probably not a whole lot of innovation in the last 7 years or so.
Okay.
And she's kind of at the forefront of a lot of the innovation. So
Yeah.
she would probably know the best, actually.
No, totally fair. And I mean, I know I'm in good hands with her. So I'm not. Thank you.
Yeah. Of course. Okay, So for masseter nerve transfers, do you see better success going to the main trunk of the facial nerve or specific smile branches? So I have never hooked up the masseter nerve to the main trunk. And the reason why is I alluded to this a little bit before, but the masseter nerve innervates the masseter muscle. The masseter muscle only turns on when you clench. So when you just hold this there, it's not on. And when you clench your jaw, if you feel it, it bulges, right? And so you have to activate the masseter nerve for it to do something. And so that's why I only send it into smile branches, because clenching to smile makes sense. But if you send it to the main trunk, you're sending a nerve that's not on all the time. It only turns on when you clench. And so if you sent it to the main trunk when you clench, perhaps you'll get that synkinesis all throughout the face. And we don't want that, right? We really want to get it to go to a specific area. And why the masseter nerve works really well for smile is that we found that over time, if people practice, they're able to smile without clenching. So it's like learning to ride a bike. You can learn to do it without even thinking about it. It becomes reflexive, but it's not emotional. It's not spontaneous. So it is different. But that's why I, and probably most of us nowadays, send it only to smile branches for that reason. And that's why I like the hypoglossal nerve or the tongue nerve to go to the main trunk, because I want something that's on all the time. Hope that answers that.
All right, I think that may be all of our questions. Thank you so much, Dr. Kim. That was really fascinating. I enjoyed it very much.
Great. Thank you so much for inviting me to speak. If anyone has questions, feel free to gather and send them off to me afterwards.
Thank you so much.
Okay.
Yes, we will. And if there is any other question, please send it to me or Connie or Michelle. We'll make sure we'll get an answer from Dr. Kim. Okay, so with that, I think we are due to look at the NF2 at the NF2 schedule of the NF session of the NF summit that is coming up in July from 22nd. So what I would like to actually from July 21st to July 23rd with the scientific program. What I would like to do is maybe share my screen. Let's see if this works. And I will go through, this is the page on CTF, CFTF page on the summit that you can get from the events, and then go to summit, and it is very nicely done with the event schedule. So what I would recommend, what I'm looking forward for the NF2 community on Thursday is mainly the session at 4:30 that I recommend. Of course, everything is super interesting, and there is empowerment advocacy sessions that I highly recommend. But if we really want to be picky about NF2 in specific, I think the donor reception and is going to be Paul Rassi is an actor, is a child of deaf adults, and also interpreter of the movie. What was the movie again? Sorry. Sounds of Metal, I think.
Sound of Metal, yes.
I love that movie actually. So he's gonna be probably exchanging a few words, but then the main thing about his talk is gonna be on Friday. So I recommend there's gonna be a keynote address at 9:15 on the 22nd, which is is going to talk about, I think, resiliencies of advocacy, sharing his personal story. I think is going to be super interesting to learn from him, especially knowing that he's such a successful actor. Then the conference will start, and there are some specific NF2 sessions that I want to point you to, especially the diagnostic updates that is going to be at 1 p.m. This is done by Dr. Caleb Yohei at NYU Langone, and he's going to talk about the really newly published diagnostic criteria for NF2 schwannomatosis, including also the new nomenclature for NF2 that is still going to be called NF2 or neurofibromatosis type 2, but also, the new nomenclature as NF2-related schwannomatosis, and the other change into the schwannomatosis, old schwannomatosis named disease. So highly recommend to finally get a grasp on the new criteria and also the new nomenclature. And then there are a few sessions for NF1 and NF2. Here, actually, we'll hear from Dr. Hadlock at MGH about a very, same topic, but probably from a different aspect of facial nerve reanimation. That is going to be at the session from 2 to 3. And then I would also like to point you to the hearing preservation and restoration. This presentation is going to be by Joshua Breckley at Johns Hopkins University and Francis Creighton. And this is going to be a medical versus surgical approach of preserving and restoring hearing in NF2 affected adults. So very interesting. I think there's going to be a lot of reports from studies, plus experience of surgery versus medical. The other very interesting talk is going to be around chronic pain. It's all across the different NF, NF1, NF2 schwannomatosis. All our patients experience significant pain at different level of a different stage of their life. So this is going to be a very high level talk about how to live with chronic pain and what are the options for managing and treating pain. And then I think we're gonna have a wrap up today. I mean, a lot of other interesting sessions, but then if we're looking at NF2 in specifics, I would go directly to Saturday. I think we are Saturday, right? Saturday, July 23rd. And this is a very interesting session again on technology for communication in NF2. Here we'll hear from Heather Thompson, Tina Childress, but also Matt Hay. So this is the ability to be understood is vital, and you can hear from experts in the field about the latest in technology, in communication technology, and for hearing aids that are available to the deaf and hard to hearing people community. So this is also highly recommended to come and listen. Few other sessions. We're gonna listen another educational session, but also very important one that I will recommend is building resiliency. Ethan Lester is from Massachusetts General Hospital. They developed a web page, a web program that will allow patients to access these new sessions to cope with many challenges in NF and living with NF. So you will learn more about this program and how you can actually access it and how it works. So this is really not just for NF2, for all patients recommended. And the other very specific talk about NF2 is the imaging guidelines and consideration in NF2 schwannomatosis. We all know NF2 is very important to monitor the progression of the vestibular tumors. So there's going to be a talk by Shivani Halawat. She's at Johns Hopkins University working with the team of Joshua Blakely, and she will talk about what, when, and why what are the imaging best practice for living with NF2 and schwannomatosis, how often is recommended to have this type of control, and this type of monitoring, and what are the new technology that are coming up to help having less impact, less burden on patients. And then a few other very interesting talk on NF1. I recommend also the family planning and testing consideration. This actually applies to all patients, where it's for NF1, NF2, or schwannomatosis, that include testing before and during pregnancy, testing for children. What are the family planning consideration? There are options nowadays for all patients, so this is going to be very, very interesting to listen to. And then if you want to listen and learn about gene therapy, it's going to be an overview session by Shivi Likhit at National Children's Hospital. We'll talk about gene therapy, very general, so probably we'll touch about NF1, NF2, and schwannomatosis, I think, but it's going to be very, very general. You'll have also the opportunity to ask questions. And last but not least, the self-advocacy and disability rights, which is going to be led by panel discussion with, Maria Stolfi, but also Eddie Putel, our national ambassador, and Ken Arcia, Clay Horig, and Simon Kamaj. That's my recommendation for you guys. I think the summit is going to look fabulous. There's a lot to learn. There are a lot of interesting programs and interesting speeches. So
Yes, thank you so much, Salvo. And in addition to all of the educational content, there's a whole menu of empowerment content that's available to everyone to learn how to be their own best advocate, to learn how to build community where they live, and to learn how to fundraise, because we need to fundraise to be able to invest in all that amazing research, right? So there is lots to learn on nfsummit.org. If you look through that entire agenda that Salvo just shared, you can register there as well. If you have any questions at all, please reach out to me. I'm happy to answer any questions. As I mentioned, it is a completely hybrid event, so you can attend no matter where you are, and we hope you will, because it's going to be amazing. That said, we are at our time, so thank you so much, everyone. We hope you have a great night, and I will be in touch with everyone who asked for more information about how to be an NF2 accelerator. Bye-bye.
Thank you everybody for coming. Bye.